So this is my clinical pearls. You're going to see a couple Bill Murray pictures in this because I'm shamelessly biting for your approval. So your case is going to be a 67-year-old male with past medical history of kidney stones, status post bilateral renal stents 2 months ago, presenting with lower abdominal pain times 15 hours. So my favorite septuagenarian, we have Bill Murray there, picture him. What do you guys want to know about him? Any questions?
Any fever, dysuria?
No fever. Dysuria, good question. So last night he went to go to the bathroom, passed 2 large clots, and then nothing after that. And since then has been seeing just like urine coming out every now and again, but can't pass any urine purposefully. And he's seen bright red blood per his urethral meatus. No fever. Anybody else? The pain is, he's just like sort of holding his suprapubic region and going, "Doc, I can't pee, this is terrible, what's going on?" Anything else? Huh?
When was the last time you urinated?
5 p.m. the night before, 15 hours ago. Hasn't since, but he has had to wear, like, he's just been putting paper towels and stuff in his underwear. He's not usually urinarily incontinent. The nurse has put a diaper on him and it's soaked.
Does he have any back pain?
No back pain. Good question.
Any history of any prostate problems?
Yes, he has BPH.
How much urine is in his bladder on the ultrasound?
Good question. So we can, if anybody has any more questions about history. Okay. So your vitals are what you would expect for a gentleman in his upper middle age years who's not feeling too hot. Like I said, with my awesome acting skills, he's frustrated, he's got a urine-soaked diaper, but otherwise he looks, appears to stated age. He's not in acute distress, he's well-nourished, but the only really significant physical finding is a palpable, what you could anticipate being a bladder, but a palpable soft mass in his suprapubic region that's tender and makes him like want to punch you when you touch it, just because he's like, "Oh, I'm gonna pee." Then you look at his GU exam, you see blood at his urethral meatus, and then, as I mentioned before, the diaper is like soaked with urine and a little bit of bright red blood. So transabdominal ultrasound for bladder. So around this point, you're getting a pretty good clinical gestalt that this is a urinary retention case, right? So you throw an ultrasound on him. We don't have like a terribly important use for measuring the specific amount of urine within a bladder, but if you wanted to measure the volume, you would do a transverse axis, and with that you can measure the widest view. So you would go from your little dot here, and if this were a transverse view, which it's not, you just measure from the dot down like that at the longest point, and that's going to be your width. And then you do sagittal view, and you do 2 cross-sectional points there at the largest points, which should be your superior or inferior view and your anterior or posterior view, otherwise known as your length and height. Multiply that by 0.52, and that's your suspected bladder volume. But anyway, the point is you put ultrasound on him and you see urine in a bladder. You don't see a bunch of junk or anything terrifying. So my topic is going to be acute urinary retention, specifically in the male, and processes for relieving them, decompressing them. Namely, we'll talk about like causes of acute urinary retention and when you can put a Foley in and when you should wait for urology, and then what to expect after putting the Foley in, and what criteria you should look for admitting. So causes, outflow obstruction is going to be your most common. This could be secondary to anything, including the urethra's passage from the bladder to the urethral meatus. So this could be BPH, constipation, putting pressure on that urethra, any urethral strictures, and so on and so forth. Or, just at the end, phimosis and paraphimosis. One really important point on this slide is neurologic impairment. So we're concerned with things that are life-threatening. So if you have a patient, even if it's not a trauma patient, but they're coming in and they're endorsing acute urinary retention, especially if it's for the first time, do your neuro exam. Make sure you do a rectal on them. Make sure they have good rectal tone, and check their lower extremities, because it could be a myelopathy. Or any other lesion that's listed up here for your spinal cord. So neuro exam is really important in this patient. Other things, if your detrusor muscle's not squeezing out the urine, medications, so you have your patient that is taking a bunch of Benadryl and has an anticholinergic response, and they're retaining, not able to actually micturate. Infection, trauma, like you guys know, any disruption of the urethra, trauma is another thing, and then just another bid for the neuro exam here, so don't forget your neuro exam on these guys. So when to wait versus when to go ahead with your Foley. I had a conversation with one of our esteemed urology residents, and they basically are cool with us putting in the Foley, except for these 3 instances. So obviously with trauma, and you guys know that's just ATLS, and we know our signs of trauma. Blood at the urethral meatus. Our guy has blood at his urethral meatus, but he didn't have a history of trauma, so I'm not concerned that he has some disruption to his urethra. Post-prostectomy, so they don't want you jamming Foleys in a fresh out of post-prostectomy patient. So they put a Foley in after that procedure, and if your patient comes in and they're having urinary retention because their Foley came out after that procedure, you're going to want to consult urology. So make sure you differentiate between post-prostectomy versus post-TURP. And then, of course, false passage. If your nurse attempted it a number of times, if you've attempted it a number of times, and then, it's causing them a lot of pain and you're concerned and you have good reason to think there's a false passage, utilize our resources. Go ahead if they have a post-TURP. There's no anastomosis in a TURP, so you can go ahead and put that Foley in. If their post-TURP Foley falls out, you can place that one. And then urethral stricture and BPH, which are going to be common causes of, obstructive.
So I think the trauma one, it's sort of okay to try once.
Yeah.
But you have to be an experienced person doing it. You can try one passage and push very gently, and if you get resistance or it doesn't go, then you should give up. But I think it's okay to try once in the setting of trauma and hope it goes in. But it should really be an experienced person who knows what they're feeling when it goes outside the urethra feels like.
Awesome. Yeah, and I think that we would all agree in an emergent situation, if somebody's going to the OR and you really want to decompress their bladder, you're not necessarily going to wait for urology, like, oh, I don't know, should I put this? So yeah, I think that's a really good point that Dr. Silverberg made.
The trauma team is likely going to be at that site too.
Yeah.
Usually it's all going to get the first of the trauma.
Cool.
This patient's going to be critically if they have a
Yeah.
Although that's probably not the most experienced person in the room. It's probably going to be us, because they don't do it as much as we do.
Right. Yeah.
But what you should really do is do a rub.
Gotcha. Cool. Thank you. So other considerations, so now we've talked about when to place the Foley and when to get some help. You can think about medical management, how am I discharging this person, and how can I make them feel better? So you have the alpha-1 adrenergic antagonists as medical management that you can start them on. Other things to know about, just rate of decompression. Apparently there was some school of thought that you should sort of slowly decompress the bladder, but that's not really what we're doing now. It's no problem, just put it in and let it all come out. And expect hematuria, so you'll see some purple Gatorade come out of some of these patients. It's rarely clinically significant, but you should absolutely be cognizant that if you're seeing frank blood loss, you're going to want to, keep your eye out for anemia and, get an hemoglobin, H&H, and always reassess these patients. And then transient hypotension, just like we see patients that have post-micturition syncope, you have this autonomic reflex. So you can see some hypotension, but it's self-limited, it should resolve. If it doesn't, obviously proceed accordingly. And then post-obstructive diuresis. So this is when somebody has had urinary retention. Usually it's more profound in the chronic urinary retention as opposed to acute. And with like bilateral kidney involvement. But basically you'll see an increased urinary output from these patients for a period of time, and you can just sort of coax them to increase their oral intake. But keep an eye on them because it's a possible reason for admission, which we'll talk about now. So if you're seeing evidence of profound dehydration, or you check their electrolytes and there's anomalies, or if you see signs of vascular collapse, you should probably start considering giving them some isotonic saline, half isotonic saline. You want to replace half of what their urinary output is, and just keep an eye on that and reassess them. And if you feel like their clinical status is going to warrant an admission, then feel free to do that. It's definitely a reasonable pathway to take. Urosepsis, obviously, if you have a septic patient, you're going to be admitting them. And then malignancy-related obstructions, I think you could probably go either way on this, but you definitely want to make sure that this patient has the proper follow-up. And if it's a critically ill patient with malignancy, absolutely admit them. And then myelopathy, again, do your neuro exam on these patients. We're ER doctors, so don't send somebody home with thinking they have an obstruction when they have actual myelopathy. And then acute renal failure, we're going to obviously admit those people. So my last slide is going to be really just some things to think about, just prophylactic antibiotics. So if you do, proper Foley placement, then and there's no signs of infection in the urine that you've collected, then you don't have to do prophylactic antibiotics on these patients. And then urethral stricture versus BPH. So just as you're placing the Foley, be cognizant of where you actually meet resistance. So if it's sort of distally along the urethral passage, it may be a urethral stricture. Whereas if you've inserted a bunch of the Foley, at least like the length of the patient's penis, then you can safely assume, or sort of gives you an idea that it possibly is BPH versus a urethral stricture, which doesn't change your management very much, but urology always likes to get as much info as they can. We like to know what we're dealing with here. And then acute A catheter, which is just something I think most of us are familiar with, but it's just a catheter with like a bent tip, and that helps with BPH patients especially. So if you know that you have a BPH patient with obstructive urinary retention, then you can feel comfortable starting with the acute A catheter. And those are in the supermarket at County. I don't know specifically where they are across the street or here.
The nurses will get them for you if you ask for it. The head nurse, Mr. Edie or Ms. Christian, will get them for you during the day. Yeah. For those who have not used it today, remember the point points up, the curve. So it's curve goes up like that. right? That's upper when you come in.
Mm-hmm.
And the major contraindication for using Credate is what?
Oh, I'm not sure.
If you think there's a stricture,
Oh,
then
okay.
you can create a false channel. So then you shouldn't. But if it's just for BPH, it is really good and
Yeah.
it works really well.
So Dr. Kushner brings a good point that the point goes through the ceiling, but to know the way the direction the point is heading, is where the port is to blow the balloon up. So wherever the port is attached to the catheter, that's also the direction where the curve is.
Mm-hmm.
All right, one of the other things too that I can't stress enough is never, ever, ever blow up any balloon until you get urine back.
Mm-hmm.
If you're not sure, then really, really, really don't do it, because I've seen so many residents blow up the balloon when they're not in the bladder and create a tear in the urethra. If you put it all the way in down to the balloon and don't get anything back, you have a couple choices. You can grab your own sound and look for the catheter in the bladder, and you're just not getting anything back because there's gel in the tube in the holes. You can also just push on the stomach and push on the bladder and try and push the gel out and hopefully get urine back. And the last one you can do is take the bag off the Foley and inject 30 cc's of sterile saline in and see if you get it back. And then you know you're in the bladder as well. You may also clear out the gel from the holes if it was blocking the holes. But never, ever, ever, ever blow up a balloon until you get something out of the hole. I've seen, I can't tell you, dozens and dozens of people with urethral tears because they blow up the balloon and then they get blood back because they blew out the urethra.
Mm-hmm.
You really do the patient a disservice by doing that.
Yeah, and pay attention to when you're blowing up that balloon, and if your patient is showing signs of discomfort, then you need to stop. Yeah, it shouldn't be uncomfortable when you blow up that balloon. It should be in the bladder.
You can use ultrasound too.
Hmm?
You can use ultrasound to on the catheter.
There you go.
And I think just a patient in particular, people, you need to remember to irrigate even if places. So this patient came in for an infection because they also had clots in there, not
Yeah.
just irrigate, so you don't want them to bounce back.
Right. Right. Yeah, you can consult your urology team, get them on board, but yeah, also irrigation, make sure, because if you just put this in and then it gets clogged up with clots anyway, you'll see them tomorrow. So it's a very good point, thank you. And then just, giving them an idea of what to expect going out. Mostly after like a week to 2 weeks, they'll do a trial without catheter with these patients. And then if that first trial fails, then they'll give them another couple weeks with the catheter and try it again. So that's just part of your discharge instructions from.
Yeah, and if you're going to send them home if there's no other contraindication, and you think they had the instruction from the prostate, which is the most common you're going to see in us elderly men, send them home on flow maps or one of those, right? You start with once at night. Always warn them that they should take it at night, and when they get up, they should get up very slow, because you can get postural hypotension even with the starting dose of 0.4. And you always start with the lower dose of 0.4 if you're using Flomax. There are other ones you can use, like diazoxide. And always get up slow. And in the morning when they get up, put their feet down, while they sit on the bed and get up slow. Because you can get postural hypotension and even syncope from it, and I've seen it.
Any questions? Okay. Thanks.